Hello and welcome to my YouTube channel. Today I'm going to start a series for the IMM Surgery and Allied candidates both for FCPS as well as the MS. I am going to explain the core concepts and the relevant topics in detail, and I will also be giving you key notes to note them down for the important MCQs. So first of all, we will be starting our discussion with the hematology and blood transfusion section. So first of all, we have the dilutional coagulopathy as the most important topic. So what it is? It occurs when a patient gets a blood transfusion which is more than his total blood volume, which is around 5 liters in less than 24 hours. So patient with trauma or burn or any other pathology who is receiving a lot of blood transfusion is at a risk of developing dilutional coagulopathy. For the management, we can administer fresh frozen plasma with RBCs and platelets specifically in a 1:1:1 to prevent this from happening. So this was a summary. Let's get into the detail. So disseminated intravascular coagulation is a seriously acquired clinical syndrome characterized by systemic activation of the coagulation cascade, leading to widespread microvascular thrombi and consumption of platelets with clotting factors, and eventually leading to a lot of bleeding and organ dysfunction. Regarding its etiology, it is caused by sepsis, malignancy, severe liver disease, soma and burn patients. Obstetric complications like placental abruption or amniotic fluid embolism can be one of the triggering factors, and hemolytic transfusion reactions and snake bites are other etiologies. In terms of the pathophysiology, so any of these etiologies will act as a triggering event and it will activate the coagulation cascade. So now, once the coagulation cascade is activated, there will be widespread fibrin deposition, that is the factor 1, and as a result, there will be microvasculature occlusion resulting into tissue ischemia. Now, on one end, there is formation of clots, and on the other end, there will be breakage of these clots. So both these factors and systems will be working in same time frame. As a result, the consumption of the platelets and coagulation factor will result into more and more bleeding, and there will be fibrinolysis, and this fibrinolysis will actually be important in the diagnosis because the fibrin degradation products which are released, they will be tested and they will give us a clue that the patient might be suffering from DIC. So what will be the clinical features? A patient who is suspected to have DIC is likely to bleed from almost every side, especially from the IV cannula side. They can bleed from their gums and even from the surgical wounds, or they can experience upper GI bleed, which is quite rare. As a result of microthrombi in the digits, there could be ischemia. In the major organs, there could be big damage like renal failure or stroke or heart failure. An organ dysfunction, liver, kidneys, lungs, CNS, all of these systems are at the liability of developing major damage. So such a patient should be diagnosed and managed immediately. So how you're going to diagnose that? So there is no single diagnostic test, but we have a few. First of all, there will be consumption of platelets, so they will be low. On the other end, consumption of the coagulation factors will be presented clinically in the form of increased PT and APTT. Both of them are going to be increased. And fibrinogen, which is factor 1, as it is being consumed, it will become decreased. However, on the other end, the more and more thrombi that develop, the more and more breakage will occur, and as a result, the fibrin degradation products, they will be elevated. So regarding the management, the very first step is to identify the cause, and we can start antibiotics for sepsis. We can deliver in an obstetric patient, and we can start the patient with chemotherapy for leukemia. Surgery and drainage for trauma or abscess patient could be vital. But the most important supportive management is platelet transfusion is required when the platelets are less than 50,000 with bleeding or less than 20,000 without bleeding. Fresh frozen plasma is administered when the PT and APTT are both delayed. Cryoprecipitate is given when the fibrinogen level is less than 1.5 grams per liter. And packed RBCs if anemia and ongoing bleeding. So all these points are very important and high yield for the board exams, especially for the IMM. So you need to remember all these values in addition to knowing the etiology, pathology, as well as the management. So the rest of the management is ICU care, which is supportive and managed according to the specific organ. So at the end, we will talk about a mnemonic, that is the DIC, where D is for the decreased platelets and fibrinogen, I is for an increased in the PT, APTT, and the D dimers, and C is to remember the clotting and bleeding simultaneously. So this sums up our discussion on the DIC, where I have explained its definition, etiology, pathophysiology, clinical features, diagnosis, and management. I hope this helps you with your exam. So thank you very much for listening to this lecture.